Bismillahirrahmanirrahim. This is part 2 of knee joint in continuation with the previous presentation of knee joint. Uh, just to recapitulate, we start with the ligaments of the knee joint, and in this diagram, it's a beautiful diagram. We see components of the knee joint and some of the ligaments. So the femur has got two condyles and the knee has also got two condyles. The anterior surface of the femur articulates with the patella, and the inferior surface of the femur articulates with the knee joint. So you got femoropatellar articular surfaces and femorotibial articular surfaces. Here you see some of the important ligaments. Anterior cruciate ligament arising from the anterior part of the tibial plateau, going backward and superiorly and getting attached to the lateral condyle of the femur. This is posterior cruciate ligament arising from the posterior part of the tibial plateau, going upwards and anteriorly and getting inserted to the medial condyle of the femur. And you can very well see the X-shaped crossing, and that's why it is known as the cruciate ligament. Here you can see a part of the medial collateral ligament arising from the medial epicondyle and going towards the upper part of the tibia. And here would be the fibular or lateral collateral ligament arising from the lateral epicondyle and going towards the head of the fibula. That will be the lateral collateral ligament. So you got collateral ligaments on either side, and you got anterior and posterior cruciate ligament. And these are the menisci. That's the lateral meniscus, and this is the medial meniscus. Menisci are the fibrocartilage. This medial meniscus is attached to the medial collateral ligament and attached to the capsule, whereas lateral meniscus is free from the attachment of the fibular or lateral collateral ligament. And there are two more ligaments which are known as popliteal ligaments. One is oblique popliteal ligament. This one is oblique popliteal ligament. Oblique popliteal ligament arises from, these are band of fibers from the insertion of the semimembranous, and they go to the superlateral areas of the capsule of the knee joint. So that is the oblique popliteal ligament, and this reinforces the posterior capsule of the knee joint. The other one is the arcuate popliteal ligament. This is arcuate popliteal ligament. Arcuate popliteal ligament is attached to the, I'll show you over here. This is arcuate popliteal ligament. It's a Y-shaped band and it's the posterolateral thickening of the capsule, and it covers the popliteus muscle. Let me see over here if I can show you a better picture. Yeah, this is a better picture of the arcuate ligament. It's a Y-shaped band on the lateral side, and this is the popliteus muscle. It covers the tendon of the popliteus muscle, which is rising from the lateral condyle of the femur. Insertion is of this is intracapsular, and then it pierces the capsule and gets attached to the tibia. So this is the posterior part of the thickening of the capsule, which is known as the arcuate popliteal ligament. So that completes the ligament of the different knee joint. Now we come to the movements. There are four main movements in the knee joints. Extension, produced by quadriceps femoris, which gets inserted into the tibial tuberosity by way of patellar tendon. Then you got flexion, produced by hamstrings. Hamstrings are semimembranous, semitendinous, and biceps. And then you got gracilis, sartorius, and popliteus. Biceps has got two heads, short and long heads, and they are inserted on the lateral side, whereas semimembranous, semitendinous, they are inserted on the medial side. Then lateral rotation, which can only happen when the knee is flexed, is produced by biceps femoris, and medial rotation is produced by semimembranous, semitendinous, glacialis, sartorius, and popliteus. So lateral and medial rotation can only occur when the knee is flexed. If you are standing up, the knee becomes rigid, and we'll explain this in a moment. Now I come to the what is known as locking and unlocking of the knee joint. Now here you are seeing the medial and lateral condyles of the femur and medial and lateral condyles of the tibia and the menisci. So when you are doing hinge movements, the movement of the tibial condyles are moving backwards and forwards on the condyles of the femur. Now what happens in locking and in unlocking? Now when you are standing up, standing up is due to by extension of the knee joint, and when you are standing up, there is full extension of the knee joint, and the knee is locked, and this helps in smooth walking of the knee joint. The knee has to be locked, unless otherwise if the knee is even slightly flexed, walking and running could be very hazardous. Now how does the knee gets locked? The medial condyle of the tibia is larger than the lateral condyle of the tibia. So the medial condyle of the tibia has to move forward to completely get engaged with the medial condyle of the femur. So this forward movements of the medial tibial condyle screws up and makes a lock with the knee joint. This is known as there is slight medial rotation because the medial tibial condyle is larger than the lateral condyle. So when it moves forwards on the surface of the femoral condyle, medial femoral condyle, it gets sort of a screwing movement and gets locked, and that causes firm extension and a firm, stable, extended hinge joint. Now to unscrew it, you'll have to undo the forward movement and medial rotation. So unscrewing is done by popliteus muscle. Now let me show you the popliteus muscle. The popliteus muscle gets its origin from the lateral condyle of the femur, and then it forms a tendon which penetrates the posterior part of the capsule, and it extends as a triangular belly and gets inserted on the supra-posterior aspect of the proximal tibia. So its action will be, when it contracts, its action will be lateral rotation of the knee joint. So the first part of the flexion is doing unlocking. So unlocking is done by this small popliteus muscle. It contracts and does the lateral rotation, and that unscrews the knee joint, and flexion can happen. So this is what is known as unlocking and locking of the knee joint. Now I come to certain bursas. Bursas are synovial spaces. There are many bursas, but the important one is suprapatellar bursa, which is beneath the quadricep tendon. And then you got prepatellar bursa in front of the patella, and you got infrapatellar bursas. This is infrapatellar in front of the patellar tendon. One is subcutaneous, the other one is beneath the tendon, that is the superficial, and this is the deep infrapatellar bursa. And then a semimembranous bursa. These are some of the important bursas. And bursitis is inflammation of the bursa due to friction. Bursa prevents friction of the bones and skin, and friction amongst tendons and bones. So prepatellar bursa is important, and this one is also important, infrapatellar bursa. When the prepatellar bursa becomes inflamed, this happens in housemaid who are working on the with the knee bend, cleaning the floors. This is known as housemaid knee. And clergyman usually kneels down, and the infrapatellar bursa, this one, subcutaneous infrapatellar bursa gets inflamed. That is known as clergyman bursitis. Now I come to some of the clinical relevance. The important thing is stability of the knee joint. Stability is done by tendons, but most of the stability is reinforced by muscles, particularly quadriceps muscles and the muscles around the hamstring muscles. And all the muscles, if the muscles are weak, uh, it can cause non-stability. Even when the tendons are not functioning properly, but if the muscles are full of energy, the knee will remain stable. So stability is not only contributed by tendons, by muscles around the knee joint. And then we come to soft tissue injuries. Remember the 3 C's. Soft tissue injury can be related to collateral ligaments, either medial collateral ligaments or lateral collateral ligaments. It can be related to cruciate ligaments. And the last C is cartilage, fibrocartilage, menisci. Menisci can be damaged. So the collateral ligaments can be damaged when there is either forceful adduction or forceful abduction. This can damage either the medial or lateral collateral ligaments. Cruciate ligaments can be damaged when there is hyperextension. Anterior cruciate ligament will be damaged, and when there is something like a dashboard injury in car accident, where the dashboard is impacted against the knee joint, it can cause posterior cruciate ligament to get torn. So, and cruciate ligaments can be damaged by either hyperextension or by forceful posterior dislocation of the knee joint. Then we come to the menisci injury. Now menisci are 2 in number. One is lateral meniscus and the other one is medial meniscus. Medial meniscus is attached to the medial collateral ligament, and lateral is free of any attachment to the fibular collateral ligament, and the lateral menisci has also got some fibers of the popliteus attached to it. So when there is any forceful injury to the medial meniscus, like impaction or twisting, unforced twisting, or flexion and a forceful abduction, the medial meniscus can come between the 2 condyles and get crushed and can rupture. Lateral condyle has got advantage because it is not attached to the lateral collateral ligament, and it has also got some fibers of the popliteus. So when the popliteal contracts, the lateral condyle is taken away from the harmful way and does not get compressed between the 2 lateral condyles of tibia and fibula. Now we come to unhappy triad. Unhappy triad is 3 injuries. Injury to the medial collateral, at the same time medial meniscus injury, and anterior cruciate ligament injury. That is known as an unhappy triad. This can happen in forceful twisting and when the knee is flexed, and usually happens in a sports injury uh, with very painful knee and knee getting um, locked and swollen and loss of movements. The bursitis we have covered, Houseman and Kalajini. So here I end my part 2. I am thankful to a number of uh, uh, anatomists who have helped me in getting these pictures. Particularly, I would like to thank uh, clinical anatomy by applied clinical anatomy by Harold Ellis. I have also uh, uh, teach anatomy, teach me anatomy, and I have touched pocket atlas of anatomy. So these uh, uh, illustrations have been taken from many of such uh, site. Thank you very much. So that's the end of the part 2.